sleepwalking. Okay, it's all correct. بس هي التقسيمة like okay. So sleep problems are probably one of the most common things you'll ever come across if you're doing neurology or psychiatry or medicine, internal medicine. You know, people complain if you're doing geriatrics for sure. That's one of the major problems. Okay, so factors that are associated with increased prevalence, okay, include female sex, mental and medical problems, advanced age, and substance abuse. So again, people who are elderly, the number of hours and the quality of sleep is going to be a lot less. So their expectations are usually very high when they come in, and so they want to sleep like they did sleep when they were much younger. So you have to educate them about the quality of sleep that would be expected for people of that age, because then if you have average or normal expectations, then it helps. Okay, so there's insomnia, hypersomnia, parasomnias, and sleep-wake disturbances.
What's parasomnia?
What's parasomnia? We'll get to that. So anyways, so insomnia is difficulty in initiating or maintaining sleep. When we see people with depression, okay, we talk about initial, middle, and terminal insomnia. Okay, so people with depression may have problems falling asleep, staying asleep, or that they wake up way too early. Okay, so we usually identify it. Okay, so it's usually due to a medical or psychological problem. So pain is very important because we usually overlook it, and they're now considered like one of your vital signs. So pain is considered like a sixth vital sign because they don't want you to overlook it. Alcohol, anxiety, depression. Now with alcohol, people sometimes drink to sleep. Okay, but what happens is eventually it becomes like they develop the dependence and tolerance, and so alcohol and benzodiazepines, eventually you need more to do the same effect. Okay, so eventually they do have sleep problems. And this is the most common sleep problem that we face. Okay. Hypersomnia is excessive sleep, excessive daytime sleepiness, or both. Okay. And again, sometimes in depression you have people who don't sleep, or then you can have people who have hypersomnia, they sleep too much. There's a subtype of depression. Okay. There's a subtype of depression that's called melancholic depression. Okay. And it's kind of atypical because they eat a lot and they sleep a lot, which is not the usual for depression, who usually don't eat and don't sleep. Okay, the treatment is sometimes different when you identify people with that type of depression. Okay, so these are some medical or psychological problems. Klein-Levin syndrome. I saw only one case in my entire practice. I've been working for like 13 years. Okay, I saw this one 14-year-old teenager who came in because he's sleeping all the time. So the characteristics of this disorder, these are like bouts or episodes where they sleep a lot, they eat a lot, and they have like, they're hypersexual, so hypersexual, hyperphagia, and hypersomnia. Okay, those are like a triad, and there's no kind of known etiology. And this kid would go into these, just like Ahl al-Kahf, he just sleeps for like weeks, he's asleep, okay? He wakes up, he doesn't remember anything of what happened. So usually they treat them with stimulants, so things that we give for people with ADHD, so Ritalin and things to kind of keep them up. All right. And of course medications, if people are like sleeping and yeah, they do cause. But the interesting thing with antihistamines is they can cause like a sort of a rebound kind of effect. So sometimes people are given antihistamines and instead of becoming sedated, they become like extremely hyperactive. So you can have this sort of reverse effect. So parasomnias are unusual or undesirable phenomena that appear suddenly during sleep or occur at the threshold between waking and sleeping. We hear of, maybe you've experienced it too. Sometimes as you go to sleep or you wake up from sleep, do you know what those are called? The hallucinations that you can get?
Dreams?
No. Sometimes you can have hallucinations as you go into sleep, and as you wake up from sleep. They're called hypnagogic and hypnopompic hallucinations, and those are normal. Okay, so you can have like sort of as if you see or as if you hear. So stage 3 and 4 ANA are known to have these parasomnias. So disturbances in your sleep-wake schedule, okay, This happens a lot when you're doing your internship, okay? When because you're sleeping at different times, it still happens to you. So you have a displacement of sleep from its desired sort of circadian period. So these are the classifications that are available, guys, okay? Because when we say like insomnia, hypersomnia, so there's different classifications that are available. There's the International Classification of Diseases 10, okay? Then there's the International Classification of Sleep Disorders. And then there's the DSM-4, which is the psychiatric manual, all right? So they put them into these groups, and the reason they do that is because they have to code. So each one of these, if you look at the DSM-4, each disorder has a code, okay? Now, what the importance of that is for statistics. So every disorder, you just put the code, and then they can, at the end, sort of see how many of what code you got, and so that's how they do their statistics. Okay, so primary sleep disorders are the dysomnias and the parasomnias, okay? I don't want to go into the details of sort of how you're going to diagnose it, but basically it's just difficulty falling asleep or maintaining sleep, okay? Sometimes we say a negative conditioning for sleep. Do you know what that means? What does that mean? Yeah, I'm never going to sleep. I'm never going to sleep. I'm going to stay up. I'm never going to fall. So it's very negative conditioning. Or you keep looking at the clock, or you keep looking at the time, or you keep looking at when is this. So this is negative conditioning. So we can treat sometimes sleep disorders if we identify that that's what a person has, and we see it a lot in children. Okay. Especially if they're anxious or fearful that something's going to come up in the dark, so all these negative things. And it's not a very easy thing to treat, and they usually end up taking some kind of medication. All right, so primary hypersomnia, where you cannot find any other cause for excessive somnolence, okay? Now, all of these things have to have a time period, so whether it's at least for a month or at least for 3 months, so it's not something that just happened yesterday. So if a patient walks into my clinic and they say, for the past 2 days I haven't been sleeping, that's not enough to warrant a diagnosis, okay? Because it could be coincidental, it could be whatever, something's happening in their environment, so you're not going to label them with a disorder, okay? So narcolepsy, because you mentioned it. You've heard of it?
Yeah.
Okay, it's a very common disorder, okay, of the sleep disorders. So it's an abnormal REM, and it occurring daily for at least 3 months. Again, REM sleep induces these hallucinations that we talked about, all right? There's a familial incidence, and it's just sleep attacks. So people with narcolepsy shouldn't do what? Shouldn't operate heavy machinery. I mean, drive, I guess. When they say heavy machinery, I mean, I don't know what that means. Does it mean trucks, or what does that mean? Trains. So most of us don't drive trains. But I think what happens is with these people who are driving trains or travel, across borders with, trucks, they usually use a lot of stimulants and things to keep them awake. So they're more likely than others to have sleep problems, okay? So sleep apnea. Do we know what that is? Sleep apnea?
Sleep apnea.
Do we know what that is? Yeah. When does that commonly happen, or what populations? So with obesity, it's a very common problem, all right? Okay, and the treatment for that is the CPAP, which is a positive airway pressure machine that they use. Or again, you can treat the obesity. I mean, that would be probably a better idea. Huh?
That's the hard
Surgery, I'll get it out of the way. So circadian rhythm, sleep disorders. So either delayed sleep phase, or jet lag, or shift work type. Okay, guys. So circadian rhythm. Most of us will probably have the shift work type, where you're you're up at night or sleep during the day. Okay. So we see that a lot in children. We see nightmare disorders, we see sleep terrors, we see sleepwalking, okay? So a nightmare disorder is a frightening dream and occurs during REM, okay? Sometimes it's a lifelong disorder, and it sometimes occurs at times of stress and no specific treatment. So when we get patients like that, ANA, when we get patients like that, because usually parents are freaking out when their child wakes up in the middle of the night and they're screaming. So what we usually tell them to do is don't wake them up, okay, because that could be more disruptive. Don't inquire about it the next day after they wake up. I know yesterday you had this and you were screaming and yelling because they don't recall it and you don't want to freak them out. You just want to make sure that the environment that they're in is pretty safe. Okay? Again, sleep terror, arousal in the first third of the night, common in children, more common in boys, commonly familial, okay? And it can develop into a sleepwalking problem, and they usually don't recall, and again, no specific treatment other than just keeping the place safe. Complex behavior is the sleepwalking. Do you know anyone who sleepwalks? Yes?
I did.
You did? Okay.
I used to go around the house unaware.
Okay, and now you're...
And then, like, nobody was awake at that time, you know? Then, like, my mother saw me, like, going around, and
Okay.
she would, like, shout, and I wouldn't
Okay. Guys, can you... I can't hear him. Shabab. Guys. Some people sleepwalk and...
They go to the kitchen and they eat.
Yeah. That's why they say it's a very complex thing, because they do, but again, it may not be very organized. Maybe they'll go as if they're going to the kitchen and eat, but then it's going to be a mess, so it's not very organized. Okay. Sorry? Guys on this side, guys on my left, please. I can't hear. Okay.
Do they do, is it like routine, like they do the same?
No. So it's different. You can tell us.
Is it a disorder?
Yeah. We all have a disorder of some sort. But the thing is, that as you get older, it gets better. So that's good news.
Yeah, I know more sleepwalk.
Okay. You sleepwalk? No. You sleepwalk? No. Okay. Okay, guys. So again, when you inquire sleep, we have to inquire about it when you have any patient come in. Like, how are you eating? How are you sleeping? Those are very common, because if you don't ask about it, they may not complain. If he's coming to you because he's got headache or he has chest pain or whatever, his focus is going to be on his problem. Okay, and then you have the substance-induced sleep disorders. Okay, alcohol and other things. Also stimulants, like often actually children who are being treated for ADHD may have sleep problems because of the stimulants that they're given. Okay. So we're done with this one. Okay. So again, this lecture is very much common sense, and I'm not going to be telling you something you don't already know. It's a social sort of more, not a psychiatric sort of issue as much as it's social. But we do see a lot of times, people brought in because they are aggressive. That was the main reason for, like, when you're on call and you get called in, is because someone was aggressive on the street or something, and even children. Okay, I do remember, like, when I was doing my residency, this 10-year-old. I thought, like, he's a little kid, right? So very aggressive. He actually kicked me. Okay, so I was in the seclusion room, and I walked in. And I'm like, he's a little tiny thing, right? And so you never underestimate the power of anybody, because completely unexpected. He just jumped and he hit me. So since that time, I would never go in unprotected. Okay. And then when I worked in the General Hospital, which is like Vancouver General Hospital, so that sort of serves a whole, like, all of British Columbia, they had security guards in the ER, like they're like 5 that size, door sized, okay? Because we used to see a lot of patients come in, like, from prison, forensic psychiatry, so they had to have security around all the time. Okay. right? So aggression basically is violence against others. It implies the intent to harm. In animals, it's instinctive, whereas again, in humans, it's more learned. I mean, we're not born to be aggressive, okay? So they may occur in clinical situations. So if you have someone who has a cognitive disorder, okay,